Hi, good afternoon all. Welcome to Surgical Holdings' third webinar. I hope that everybody is safe and well and keeping safe. This webinar, I'm particularly grateful for Nick Williams, who has kindly put himself forward to present for us today, or alongside me, on rigid endoscopy, insight and an insight into the usage and maintenance of endoscopes. Maybe looking at rigid endoscopes. The presentation, if you've followed any of our previous presentations, will be the same sort of format. So we'll run through. There's the option to send over questions, which can be done on your control panel, and I will see those questions as they come through. If appropriate, and it's something that you would like to get a question on during the presentation, we'll do our best to answer it if it's obviously relevant to the subject matter at the time. Just to give a bit of Nick's background, so Nick has been involved in medical devices for over 30 years. I'm sure he'd be delighted me saying that. And he ran he's actually MD of Olympus for how long, Nick? Sorry, just to butt in and give me a bit of factual information.
5 or 6. I don't want to talk about myself. 5 or 6 years, and then executive for 10, 15.
Okay, so he knows a bit about scopes, and I'm sure you will enjoy this presentation. Just final thing to mention is if we get any time at the end, we'll open up the microphone, but we'll probably stick to just the format of typing in questions, because that's, from previous experience, that seems to work better. We're gonna click off our faces now, and Nick will take it away. Thank you, Nick.
Thanks, Dan. So, hello everyone. As Dan said, I'll click off my face. I'm not sure if that's an act of vanity or compassion for you, as I have been in the industry for quite a long time. Yeah, Dan's asked me to give you an insight into rigid endoscopy, really where rigid scopes are used, and also an insight into sort of care and maintenance of those. So I'll go straight in. And the overview of the presentation, we'll talk about what is endoscopy, give some examples of rigid endoscopy. I'll give one example, a bit of background on laparoscopic surgery, and then talk about care and maintenance, really, of rigid endoscopes. So, endoscopy. What is endoscopy? Any oscopy is, oscopy means the viewing of, so microscopy, viewing of small structures. Endoscopy, endo is inside, so endoscopy is looking inside. Endoscopy, in principle, as I am very old, my recollection of endoscopies goes back a long time, and historically there was really 2 basic types of endoscopes. You either had a flexible endoscope or a rigid endoscope, and in general flexible endoscopes go in God-made openings and rigid go in man-made. There are some exceptions to that. But it was much more black and white, and it's now much more grey, as I'll talk about through the presentation. But I think if you probably just Googled endoscope on any search engine, it would probably bring a flexible endoscopic procedure, probably colonoscopy, as that's very well known. We're not going to be talking about flexible at all. We're purely going to be talking about rigid. And there's a lot of rigid endoscopic instrumentation associated with rigid endoscopic procedures. We're obviously going to be talking about endoscopes, but I wanted to also highlight that there's video systems that take the image from the endoscope and show it to all those in the operating theatre or in the endoscopy unit or wherever the actual procedure is being done. Lots of developments in hand instrumentation. And also energy devices. A lot of different technology in energy devices has come through in the last few years. And then there's fluid management technology for those endoscopic procedures that are done in fluid. So there's a lot of equipment associated with rigid endoscopic procedures, but we're only going to be talking about endoscopes for today. So I mentioned that they are rigid and flexible, and they historically, you could probably say that rigid were used in theatres or ORs for those of you in America, and flexible in endo units. And it was a pretty black and white situation, and it's now become very grey. And just to illustrate that, Hopefully you'll see my cursor on the screen. This is an example of an old fiber optic endoscope with an eyepiece, fiber optic flexible endoscope, and a rigid resectoscope for urology. That was historically what was the case, and now you've got things which have got flexible tips. This is a rigid instrument used, as you can see, with laparoscopic surgery. And then the other picture here is actually related to a notes procedure. I actually ran a surgical business in the States for about 4 years. And at that time, there was a lot of natural orifice interest, using scopes through natural orifices and taking out, for example, in this situation, a gallbladder through the mouth. And I was at a procedure where a gallbladder was taken out through a vagina. The idea was basically there would be no scars, but actually the shall we say, the problems associated with using very small instrumentation really outweighed the benefits of that. So it didn't really take off, but at the time it was very interesting. But that's just to illustrate there's a lot of grey area now, not just simple, rigid and flexible. So let's talk about a rigid endoscope and how it's constructed. There's a variety of parts to it, but it's probably best if I actually just show you a broken down instrument. This is a very simple, small diameter, broken down endoscope. On the left, you can see the eyepiece, then moving right, there's the ocular system that integrates with the eyepiece. The housing, you can see this post there is where the light guide cable connects and takes light through down the shaft using fiber optics to the tip of the instrument, and then the lens system returns the optical image through and back to the eyepiece. There is, as I say, fibers. Many people forget there are fibers within a rigid instrument, and that's just an illustration of that. But I think if you just use this simple system as an example of what we're talking about today, basically the main difference really is in the method of getting the optical image back. Obviously, something that's quite small diameter with rod lenses is quite breakable. And there's various different types of optical systems for the lens system, either a standard rod lens or what's known as a hybrid lens system with achromats. So it's integrated achromats with rod lenses. And then you can also get the optical image back here by substituting these lenses with a fiber optical bundle, what's known as a coherent fiber bundle, where all the fibers are stacked in order, so you can, it acts like a pixel on a screen. The top right fiber at the distal tip is the same as at the proximal tip, so you can then get an image back. The advantage of using a fiber lens system is it's more flexible, and so often you find that that's used in very thin instruments that need to be more flexible. And then nowadays there are also chip on tips, so this lens system is completely not there, and there's a chip basically at the tip, an CCD chip or a CMOS chip at the tip, which will take the image back via wires. So we'll talk about some of those later on when we talk about the number of different weird and wonderful scopes that are out there. So design criteria behind endoscopes, I mentioned there's a lot of them, and the reason there's a lot of them is that there's a lot of different uses for them, both diagnostic and therapeutic. So what are the design criteria for any endoscope designer, any endoscope company? The first is obviously the overall size, the outer diameter of the instrument. How big is the hole that you can actually go into? Obviously, the bigger the hole, the better you can use, better optics, more light, more channels for therapy, etc. And I mentioned, is it diagnostic or is it therapeutic? If it's diagnostic, you're really just interested in looking at it. But obviously, when you're there, if you can do some therapy or do something about whatever you see, that's a far better one-stop for the patient. So a lot of endoscopy developments or endoscopic developments over the years have been moving from diagnostic to therapeutic. If you're going to be doing, if you want to see something, sometimes you will need some fluid or gas to actually visualize, and also to do therapy. So you'll need channels for fluid, and you'll also need channels for therapy, biopsy, whatever you're going to do using that instrument. Light is something that should never be forgotten about. You need good light in order to see, in order to visualize, and then more and more relevant nowadays is serviceability, how serviceable that instrument is, and then protein adhesion. Obviously, that's become a much bigger issue now. So endoscope designers are now using materials that have reduced protein adhesion. And then the be all and end all is how much is it, and what is a user prepared to pay for something. There's a lot of technology out there. For example, with miniaturization, endoscope manufacturers can do huge things, but if it's really, really small and make it very, very interesting, the cost per procedure will go up significantly. And will health systems actually pay for that cost per procedure is a big question. So let's give you some examples of endoscopies. One oscopy example is arthroscopy. What is arthro? Arthro is anything to do with joints. So arthroscopy is putting an endoscope into joints. It's a rigid procedure, and the really common one is obviously knee, but really there's many joints as I've listed there, including the TMJ, the temporomandibular joint, and generally what is used is a small diameter rigid instrument for an arthroscope, usually 4 or 3 millimeters, varying degrees of view, 0, 30 or 70, which I'll come back to in a minute. And then it's connected to a video system, and there's a huge range of instrumentation arthroscopically to then do whatever you need to do. That's an example of a knee arthroscopy. It's a 3 puncture in this case, and you'll see something like that through the endoscope and through the video system, which is, as you can see, very white. There's no blood anywhere. This is just the meniscus, the cartilage in the knee, the meniscus in the knee. Another example, I just want to give you some, again, background on some actual procedures. Cystoscopy. Cyst is associated with bladder, so cystoscopy is looking into the bladder. In this case, it can actually be a rigid or a flexible. There are flexible cystoscopes, and you're generally looking at the urethra, the prostate, and the bladder. Equipment the same. You need an endoscope, a video system, and some instrumentation. This is a graphic of a cystoscope. And I mentioned before, in terms of the direction of view being either 0 in the cystoscope, it can be 12 degrees, 30 degrees, 70 or 80 degrees. And that basically means a 0 would be flat at the distal tip, 30 is forward oblique viewing, and then sideways viewing would be 70 or 80. And you'd interchange these cystoscopes through the sheath. This is actually an incorrect diagram because it doesn't actually have a sheath. But you'd interchange cystoscopes, take a 30 out, or a 0 or a 12, and then put in a 70 or an 80 to look at the bladder neck.
Sorry, Nick, just one question that came up there from my perspective. Obviously, you described the different angles of obviously the scopes, and and this is why it's so important that when scopes are maintained through their course of their life, that they do have the correct lenses and angles and specifications adhered to.
Yeah,
is that right? Yeah,
absolutely. I mean, one of the things I'll show you in a minute is TUR, which is a transurethral resection, so a resectoscope. If incorrect lenses are put into that, and you get the wrong sort of field of view and direction of view, and you're trying to do a resection, you may not see what you want to see. So typically you won't see the beak of the sheath, for example. So it is very important that the repair is using the appropriate lenses and getting the appropriate field of view and direction of view.
Okay, sorry for interrupting.
We all welcome. I mentioned TUR in cystoscopy. This is an example of a resectoscope. So this is actually a resectoscope where they've got a loop at the tip here, which will be moved using what's known as a working element here, back and forwards. The basic design problem with this in comparison to arthroscopy is you are just using the urethra, so you effectively only have one port. So everything has to be designed to be used in that one dimension. Whereas with laparoscopic surgery and well, laparoscopic surgery that isn't single port laparoscopic surgery, I should say, and arthroscopy, for example, you'll have multiple ports, so your design will be different. But the basic design is to have an integrated system with a cystoscope, a urethrotome for cutting the strictures in the urethra if necessary, a resectoscope for either TURP or TURB, so transurethral resection of the prostate or transurethral resection of the bladder. And the scope design, very similar to arthroscopes in terms of the size and the degree of view. There's usually a 12 degree or a 30, some zeros, and a 70 or an 80 degree for the bladder neck. That's some examples, not particularly good pictures. I got these off the internet, sorry, in terms of picture quality, but that's an example of some pictures from a transurethral resection of the prostate. And you can see here you've got the loop, and the loop will basically will be connected to diathermy or monopolar or bipolar, now much more bipolar. And there'll be transurethral resection nowadays in saline more than in glycine, which is another fluid that's been historically used with monopolar diathermy. So the loop will be pulled back, and gradual chips will be taken off the prostate, increasing the area for flow of urine. And this is a very common procedure. I mean, I think 1 in 3, it may even be 1 in 2. So probably someone, either Dan or I, will have what's known as benign prostatic hyperplasia, or BPH, and you have an enlarged prostate that can stop urine coming through. And you'll then, if you're not treated by drugs, you may well have a TURP, which has been viewed as the gold standard in this area for many years. So that's an example of another oscopy. I thought I'd give you an example of laparoscopic surgery, and the classic one was the procedure that actually really had almost a revolution in surgery many years ago for going from open to laparoscopic, which is laparoscopic cholecystectomy, which is the removal of the gallbladder. I thought I'd give you a bit more background into this because this is the only one I'm going to be showing you for background in terms of endoscopic surgery from a laparoscopic surgery perspective. The patient will present with upper right quadrant abdominal pain usually. Gallstones are usually diagnosed with an abdominal ultrasound. This is an example of a normal gallbladder, and then there's a gallstone with an acoustic shadow beyond that. The sound comes from here, hits the surface, and then is all reflected, and therefore it's quite easy to see on ultrasound because you see a shadow. The patient will usually have cholecystitis or maybe also pancreatitis if there are associated stones that lodge in the biliary system and then stop pancreatic enzymes leaving, going into the duodenum. That can also be a problem. And then nausea and jaundice you'll usually see because of a blockage, and you'll get bile going into the bloodstream and showing as jaundice. Obviously, many years ago, all of these were done from an open perspective, and some are still done from an open perspective, but most are laparoscopic. And open are tending to be due to conversions from laparoscopic due to problems, or if there's a particular problem with the patient from a cirrhosis or an actual bleeding problem. The advantages of lap V open: reduced pain, shorter hospital stay, shorter recovery time. So basically the patient is usually preferring those variables to an open set of variables. I mean, I actually have I've developed an inguinal hernia in lockdown, and so I've now booked a laparoscopic hernia repair whenever procedures are starting up again. And the reason I've done that is really for reduced pain. From an equipment perspective, and obviously we're getting back to the endoscope itself, really should think of the needs for the surgeon's eyes and hands. And from the surgeon's eyes perspective, not only is the endoscope important, but the camera system. It should really be a high definition camera system nowadays, either sort of something like 1080p or 4K, so like the equivalent of your high definition TVs at home. It could be a 3D. There are 2D and 3D options available. And the laparoscopic system could be mounted either on a trolley or a cart, or wherever you're, depending on wherever in the world you want to call it. A cart, a trolley, or a stack is usually what I've heard. And it could also be taken off. As you can see, this is the picture on the right is quite a sort of almost like an old hi-fi stack system, not particularly ergonomic, and you can make it a lot more ergonomic by taking it off the floor. But the reason for this graphic is really showing you these are just the total number of examples of different scopes that can be connected to that one stack. So there's an awful lot of different scopes out there for varying different procedures. I've mentioned that you've got a stack like that, but equally something that's off the floor in what's known as a OR integration, or OR of the future, or theatre integration, wherever you, depending on whether you're in the States or in the UK or Europe. And you could also have 3D. This is an example of a 3D system where they're wearing glasses to see the picture in 3D. The advantage of 3D is really it gives you better depth perception. So for something like laparoscopic suturing, it should be better, but equally there are many. I won't get into the benefits and the pros and cons of 3D versus 2D, but there are pros and cons for both. And you may have a robot in your hospital. This is an example of a robot where two surgeons are sitting at the robotic stations, and the assistants are at the where the patient is, with a variety of different robotic instrumentation. The procedure itself, getting back to the endoscope, this is where the laparoscope is. Basically, it will be placed usually at the umbilicus, at the belly button, and there'll be other ports here. So you first of all create what's known as a pneumoperitoneum. So you blow up the stomach, so you've got room to actually operate. This is the sort of a smaller picture that is showing you the sort of area of interest. You retract the liver, expose the gallbladder, dissect the gallbladder away from the liver, and dissect the cystic duct and artery. Then ensure that once you've got that dissected, you'll clip it, seal it, and then cut the artery and the duct. Potentially you would do in some countries a cholangiogram, which is just then checking to see if there are any residual stones in any other part of the biliary system, and potentially then go in with a scope called this flexible scope, actually called a choledocoscope, to remove those stones. You take the gallbladder out and then you close. And as I've shown you pictures of relevant pictures of arthroscopy and cystoscopy, here's an example of something you'd see with a standard laparoscopic endoscope connected to a camera system. This is the gallbladder, instruments here, liver, and it's just as they're moving the gallbladder back, and they will then have to dissect out the area here, which is known as Callow's triangle, and basically get the cystic duct and cystic artery clipped and cut. So that's background really in terms of where how the endoscope's made up, and also where it's actually used. Some examples of endoscopic surgery and basic endoscopy. But we'd also like to talk about maintenance and repair, so care and maintenance really of these scopes. I've been working with Surgical Holdings for a number of years now, and the reason obviously we're talking from this perspective is that they've had a dedicated endoscope repair lab for some years. All the repairs are done in the UK. I'm not going to push Surgical Holdings as an endoscope repair option for you, but clearly that gives us some ability to talk about the subject. There are lots of different types of endoscopes. I've highlighted in earlier slides just the sheer sort of versatility and flexibility of them, and they are used in all sorts of different areas. As we're just talking about rigid scopes, I've just made a few lists of some of the ones that you may routinely see or hear about. Laparoscopes are used basically in laparoscopic surgery, so usually through the umbilicus. Arthroscopes we've already talked about, hysteroscopes for gynae, and then resectoscopes and cystoscopes and nephroscopes all in urology. Nephroscopes are usually what's known as percutaneous nephroscopes, and they are, so you're going into the kidney from the back of the patient. They're used in the thorax, in the brain, and even in utero, looking at fetuses. All of these are I've grouped in terms of the optical system, because these are usually using rod lens systems, semi-rigid or semi-flexible, as some companies call them, are using an optical system based on fiber optics, and they're usually a weird and wonderful small scope for pediatrics, or a very common scope that's used is in upper tract urology, which is a ureteroscope, and that's inserted into the ureter, usually for getting rid of stones in the ureter. And I mentioned chip on the tip earlier, so these are instruments where the image is produced from a chip at the distal end of the endoscope. The advantages of these is you've got effectively a chip right where you want it, and you can also flex these quite significantly, so they're pretty robust in terms of bending them. The disadvantage is if you break them and you get any ingress in fluid ingress, for example, onto the chip, it usually goes, and that's a very expensive repair. So all of them have pros and cons as per normal in things. So to summarize, rigid instruments are generally small diameter. I mean, probably the biggest instrument I've just listed there would be a 10mm laparoscope, but laparoscopes usually will be 5mm now, 5.5. They're therefore fragile. So we're really talking at 2, 3, 4, 5mm instruments, and they can be easily damaged either during the procedure or via handling reprocessing. So to talk about maintenance repair, improved maintenance will decrease your repair spend, for sure. You'll definitely get repairs because these are fragile things, but good maintenance and care and maintenance will decrease your repair spend. So things you can do: routine inspection. I mean, with the COVID situation in the UK, I'm sure once theatres start getting up and running again, it'll be quite interesting to see how these trays have been for some time, and how the instruments have been, particularly if they've been left with a lot of condensation in them or something like this. For example, power tools could be very interesting, how that's going to survive over a number of weeks staying in storage. So I think it's very important to, particularly now with the COVID situation, routine inspection, have a look at everything, check all the outside surfaces, see if there's anything sharp. Obviously don't just run your fingers down it, but have a look at the outside surfaces, look through the optical system, does it look reasonable? Ideally connect a light guide and check the light quality through the scope. Obviously, if that is the case, that the light isn't good, it may be the scope, but it may also be the light guide cable. So connect the little light guide cable very quickly just to see if it's the light guide cable. And ideally always have spare light guide cables, because they're relatively inexpensive in comparison to the entire imaging system that I've just shown you. It might be an imaging system that's £100,000 and you've got a light guide that's a few £100, and that is the variable that causes a real problem with the overall performance of that very expensive imaging system.
Sorry, Nick, just one thing I meant to pick up. You mentioned about the baskets, and that's something that we see quite a lot. Is obviously when the rigid endoscopes are reprocessed, they're put in baskets that are appropriately fitted to the scopes, because quite often we'll talk to customers who maybe assume that this is that they have the correct protective equipment needed in these baskets, but very often the baskets may be causing the damage themselves. Would you say that's would seem quite a high possibility on a lot of the small diameter scopes?
Yeah, very much. And I think if if very much look at the basket. I mean, for example, the two extremes are where you have to really force the endoscope into the basket to get it to sort of fix itself. That the sheer movement of that might be damaging it. The other side, if it's not fixed in a basket, it can move around and you know, I mentioned power tools, for example. You might have it in a tray with some very heavy items that then move around during transportation and potentially damage it. So I think it's very important to have good baskets that will hold these things safely and securely. It may well be you just need to, you know, rotate a basket. That may be one particular tray that could be used in something else and changed over. And but there's certainly a number of options on baskets, but they are very important.
Yeah, I think, you know, you mentioned about how when perhaps scopes are in trays with other tools and instruments, but I think sometimes when we've received instruments for repair and the scopes are within or mixed in amongst those instruments, then there's obviously a high chance that the damage that was perhaps minor could be significantly increased for that. So I think that's certainly something for people to be aware of when they're you know, making sure that perhaps in this time when people might have a bit more time to actually or to review how the scopes are laid out and what baskets they're in.
Yeah, I think it's a very good time to, I mean, because certainly in the UK, I don't believe elective surgery is taking off really in great numbers yet, and it's a good time to really just check out your equipment, see if it's okay. And on that particular, I mean, orthopedics is a classic example. You know, arthroscopes are probably the most fragile things in an orthopedic surgeon's armamentarium. And, you know, power tools and drills and chisels and everything else, it's all big and bulky and you know, completely different in terms of its fragility.
Sure.
So it would be, I think, a good time to look at trays, and if you do see something that is not fixed properly, look at the tray you've got and see if you could redo it or get a new tray. And hopefully, you know, it's all about prevention of repairs, really.
Yeah, well, that certainly the image of the cystoscope is scarred into my brain now. I think when we're talking about checking the outside surface of the device and making sure they're not sharp when they're being used in the areas they're being used on. But sorry, please continue.
Yeah. Well, that's actually a picture. That's a cystoscope in the picture on the right hand side. And I said do simple things often. You know, look at the instructions for use from your manufacturers, and these taps here, for example, keep them lubricated. Otherwise, what will happen is that they'll just leak, and so the urologist in that situation is getting very wet, or a very wet floor. It's a wet procedure anyway, but what you don't want is leaking taps. So simple care and maintenance can really improve and prevent repairs. I'm often asked about sort of repairs and repair providers, and I did a podcast recently on something along those lines, and I don't make any attempt to sort of suggest anything at all, other than just simply look at the QCD, the quality, the cost and delivery. All three are important. You might have a provider that is fantastic at quality, gives you a very good and competitive cost, but they can't deliver for 3 months. And unless you've got a lot of inventory, that can be a problem. So all three of those are important. And if you are looking at a repair provider, go and have a look at them and see them, because I'm sure all reps will say how fantastic their labs are and the culture of the company is, but by going to see them, you can actually get a feel for that. Some damage examples of repairs. There's repairs, as I said, these are fragile, they will break. There's normal wear and tear damage. Autoclaves are not wonderful things for fragile instruments. There's obviously expansion and contraction due to the heat, so there's friction, the lenses move, there's spaces, in fact in some larger scopes there's even springs to counteract the expansion, ensure the expansion contraction. When it contracts after the autoclave, everything goes back into place, but that can cause damage after a while. Insertion and retraction from the shaft, particularly if the shaft is damaged, that can lead to problems with the endoscope. And the light source, if it's inappropriate, using an inappropriate light guide. A classic one would be a light guide for a large scope on a small scope. You're getting too much power from the light and you'll get problems.
That is again something that we've seen quite often, and it's sometimes perhaps that that light guide cables may get mixed up, and they're so generally all quite slim in diameter anyway, so it's easy to mix them up and make that mistake. So it's certainly worth double checking that, because obviously that can, you know, be potentially very, very hazardous from a heat perspective.
Yeah, and as I highlighted earlier, in terms of performance of an expensive imaging system, a light guide cable is probably, it's really useful to have extra light guide cables in your cupboard for problems, because they're really quite inexpensive, but they're absolutely critical to the performance of the system. So just have, as you say, have many. I would have big ones and small ones, plenty of spare ones, just in case it's damaged when it comes out the tray. Other external damage, mechanicals, as we've highlighted. One of the things that does happen often with damage is purely through the procedure. So you might be using something mechanical like the shaver or a lithotripter. In the case, a good example of that will be in an upper tract urological procedure where you've got a ureteric stone, and the ureteroscope will go up with the lithotripter. The lithotripter will bang away at the stone and get rid of it, but the lithotripter may also bang against the distal window and cause problems. Heat may also do the same thing. You may be doing all sorts of weird, maybe with a laser, for example, and causing damage, usually again to the distal tip of the instrument. And then there's shock damage. These things are dropped. People do drop things, and you know that often leads to shock damage. Giving you a few examples of pictures of damage to scopes. This is due to shaft bending, classic cracked edges around the circumference of the instrument. Heat damage, you can see particularly here, there's quite significant heat damage that's occurred at the tip of that. That's the distal window of the instrument. Shaver damage, again, you can see that this should be completely flush, and as Dan's highlighted, you can quite often get some quite sharp edges on these distal windows from this, which is obviously quite dangerous. And then, as Dan's also recently highlighted, incorrect light guide use. That's a classic sort of thing that you'll see. You'll get discoloration, and it will often be burning the area. So to summarize, there are lots of instruments, lots of different ones. It can be quite complicated, but pretty well all of them are fragile. So really, care and maintenance, what we're talking about is in reducing the many different forms of damage that are highlighted there, whether it's via procedure such as a shaver or a lithotripter, processing such as autoclaving, or shock damage or mechanical damage due to inappropriate use with a bent sheath. The repairs, as I've highlighted all along, are inevitable. These things are fragile, and really what we're talking about is reducing the number of repairs, preventing those repairs, and if you do have repairs, they are likely to have consequences in terms of the downtime and your overall performance. If you decrease repairs through better care and maintenance, you will save money and you'll improve overall efficiency. Will you get thanked for it in terms of you've just prevented a repair today? Unlikely, but improvements will prevent problems. And to quote Albert Einstein, whilst you won't get a lot of thanks for preventing problems, intellectuals solve problems, but geniuses prevent. And that's it, Dan. Thanks. So thanks for listening, and if there are any questions, we'll try and answer them.
Okay, thanks, Nick. I've just popped back up on the camera. We've had a couple of questions come through, and observations as well. So Darren, who is down in Cornwall, has just mentioned that with regard to light leads, that they've actually started to put GS1 marks, laser mark on them, and to have them track with the trays to prevent instrument migration.
Yeah.
And it just ensures that the right light lead is with the right scope, and that a practice like that will certainly save a lot of money, although investing in the initial time. But that's if you're ensuring that the right leads are with the right scopes, that should make a big difference, Nick, shouldn't it?
Yeah, really, it's a good idea.
Yeah,
yeah. I would also still have spare ones because they are relatively inexpensive, hundreds of pounds.
Okay, and we also have a couple of questions from Hank Bausch, who some of you may know as from the world famous Beyond Clean podcaster. He didn't tell me to say that, did he? But so Hank's got a couple of questions here, and he said, not sure if it not something we've mentioned, but is within the sterile department. Should we be thinking about, you know, higher technology inspection tools? We've seen certain machines that you can put the scope into that will give you a report on the scope. I mean, my perspective is obviously seen those machines, but also it's also alongside that a good advantage to have well-trained staff that can do simple inspections. Some of the things you've mentioned can be easily picked up, can't they?
Yeah. I mean, ideally, I would say yes, but there are practical issues with that. I mean, there's obviously the cost of the technology. There's the practical aspects of that. You know, you're using that as an instrument of precision to check the accuracy of something, and you know how precise, how accurate is that instrument? You know, who audits the auditor, kind of thing. You know, that particular technology may drift. And so you'll need to have it regularly assessed, and it takes time. So that's a very crap way of answering that question, because I don't really have a yay or a nay on that. I mean, ideally, it'd be great to have, you know, optical testers for every instrument. You could stick it in, make sure that the direction of view, the field of view is there, and the same with light guide testers. So ideally, yes, I would say that. But there are practically, you know, are you going to be able to ensure that you have the time and resource to do those things on every single instrument you have?
Sure. And Hank's also gone on to say best practice in terms of tracking your scopes that go out for repair. Should you expect to get the same scope back? And if not, how should it be tracked by the user? So obviously, you know, the hospitals who are sending out their scopes for repair obviously want to make sure they get the right scope back, and how can they take those steps to ensure that's the case? Obviously, you're assuming that if they're working with a company doing the repairs, that they would have adequate tracking and trace their end. But what can the user do?
Yeah, well, I mean, obviously it depends on your individual systems, but I think it's obviously very important. These things can I mean, you can get into all sorts of different discussions about the advantages of centralizing or decentralizing, but ensuring that you have appropriate procedures, that when you do get something back from your repair, you know exactly where it's going to go in what tray. I mean, I know you have a system where the customer can actually access the repair. So it may well be you work with your provider where there is a code you can put in a field to say this is cystoscope from tray 11 or whatever it is. I mean, that's something to work with your own repair provider, and then you can then check that back.
Sure. Okay. Because obviously, you know, as you mentioned earlier, you mentioned about the protein side of things. We want to make sure that there's full traceability, well, as far as you possibly can take it. I mean, obviously, when we're doing the repairs from the parts perspective, every traceability is taken every step of the way, all the through to every individual component that's used. So I think if people are sending scopes in, they should be able to ask for that backup on that. Obviously, what's gone into their scope. Personally saying that would be something that we would do. I had a question myself, because I don't think we've got any others. Oh no, so we've had a few more come up now. Excellent, which is good. Let's just have a quick look. So Michael Palazzo, are there any recommendations on how to clean these instruments properly with proper detergents? I mean, that's a bit of a tricky one to answer. Generally, I think it would have to be just look to follow manufacturer's instructions, really, Nick, wouldn't it?
Yeah, that's yeah, it's simple as that. It would be a case of, I mean, obviously with you know, from an endoscope manufacturer's perspective, if you're launching a piece of technology globally, there are all sorts of different detergents and disinfectants and sterilizations and you know, pressures and temperatures around the world. So it would really be, unfortunately, I can't say anything other than you have to contact the manufacturer to say, is this recommended with that? They will have a list of what is recommended. Most manufacturers will also have a list of what is not recommended and not recommended, if you follow me.
Yeah, sure. And I suppose that's, you know, that is something that would be part of their validation as well. I know, obviously, I mentioned Hank, and that's obviously the validations and information provided by the manufacturers is something that's very close to the Beyond Clean's heart, ensuring that hospitals get the right information to ensure that these devices can be reprocessed safely. I've got a couple of other questions. So Andrew has said, in regards to repairs, there's a question. Sorry, right, okay. So they're just saying, this question is basically saying around third-party companies repairing versus when they're done by the manufacturer. I mean, probably something more for me to answer. Obviously, being a third-party repairer in the UK and the US, generally all over the world, you'll have third-party repair options. I think the question is liability-wise. Of course, generally speaking, as a repairer, would be liable for the work we carry out, and to ensure that's carried out in accordance with our quality system, tested and checked in accordance with our protocol that we have, which is regularly audited. So there's probably not a great deal else I can say on that particular question. Have a quick look. So the next one. So here we go. There's one from Adrian, who says, track and trace is great where the company actually does the repair. There are some companies who operate some exchanges or repair exchange, and that can defeat track and trace. But I think that's just picking up on really the other question we mentioned, that that it's obviously the importance is knowing origin of the device, I suppose, that you're buying. And obviously, if it's something you're working with that replaces the scope, then you would get adequate assurance that, of course, that scope is fit for purpose. So it's difficult for me to answer that because that's not something we do as such. But is that something you've got any experience with, Nick?
Yeah, I mean, it's no, not, I wouldn't say too much more along that. I mean, it's a, you know, protein is a real problem with that. When CJ first came out, it was a real nightmare. I mean, in terms of general perspective, is it better to have something repaired or repair replaced? I wouldn't make an opinion on that. I mean, and again, the companies that are suggesting repairs and the companies that are suggesting repair replace will obviously give you an argument as to why they think that's better. I would just say from a general perspective that it's you know, reiterates again about QCD and the quality of the repair, the cost of the repair, and the delivery.
Yeah, it's a commercial decision, really, isn't it? And I think any company generally that is offering that would have to have appropriate qualifications to you know, with regards to traceability. But again, I suppose that's if that is being carried out, and then replacement, whether it's replacements or a repair replace option, that traceability information would have to put back into the hospital's traceability systems to ensure that, you know, again, the right light leads are picked up for the right scopes. Kelly has asked, how do you answer a customer that asks how many times a scope can be repaired versus replacing it? And actually, I've got one of our technicians who I've seen come online, who I'm going to try and put on the spot with that question, which I'm sure he's going to love me for. Jack, can you hear me? Hello, Jack. Oh, I think you just barked.
Can you hear me?
Yeah, I can hear you. Got you. So
Alright.
I've just had a question which I think you'll be more suited to answer, just to put somebody else on the spot rather than me, really. Kelly has asked around how many times a scope can be repaired versus replacing it. I know sometimes we'll get in scopes that are very, very, very old and have been repaired and can be repaired quite easily. But is there a limit to that, or as to how often something can be repaired?
There's certainly a limit to it, but it all depends on the severity of damage,
Right.
and how many times it's, how often it's been damaged quite severely. So if you have something that's had a bent shaft or has had major damage to the proximal housing, then it's better to get replaced straight away. But if it's had consistent minor damage throughout its usages, then it can go on for a very long time. We can see the same scope up to 5-6 times maybe before it's needed to be replaced. So it all varies depending on the damage.
Sure. And I suppose, Nick, this is where we're talking about the smaller diameter scopes, but potentially, obviously, they're going to be damaged more often, aren't they? So maybe that's Jack, the smaller scopes that might have potentially a shorter life cycle because of that. And as you say, if there's only so many, if it's a bigger scope and it's got a lot more rod lens in it, you wouldn't want to continuously potentially replace those lenses. If again, I think it's come down to Nick. What was your acronym, or your saying that you mentioned?
TCD.
Okay.
Yeah,
So,
well, I mean, from that perspective, it's a bit. I mean, I'm afraid the Americans probably won't understand this, but the UK people will. I mean, it's a bit like Trigger's broom. I mean, if you repair it enough, it will be effectively a new instrument. So if you could argue it's unlimited, but really, the point Jack's making is it might be better just buy a new one.
Sure. Okay. Thanks, Jack. Don't go away because I might have something else to ask you. Okay. So Julia has asked, can we mention about light calls and when they may need to be removed from service? What would constitute that? Why would you need to throw away a light cable?
I think again, just test it and see if, as long as the light is coming through and you think it's reasonable, it should be not an off color light, and it should be bright. I mean, you can get, as Hank was saying, you can get machines that will test light guide cables, which are more qualitative. But from a quantitative perspective, it's really, am I happy that it's bright, it's coming through, and it's not off white or yellow or whatever it should be. I mean, with the in the old days with the fiber optics, you could literally just put it to a white wall and see if there's any fibers that have been broken. You'd see how many black spots there were. So it can be done, I think, reasonably without technology. And as they are relatively inexpensive, I think it'd just be a case of, if you weren't too happy with it, just replace it.
Yeah, sure. So I mean, it's, as Nick says, there are machines that can be used to test these, but yeah, it's generally, you'll see, won't you? You can see, if you're used to looking at light cables, you'll get used to the amount of output, and even just holding it up to the light, you can see how many of the fibers are damaged. I think that's a similar, I guess, a similar diagnosis tool could be used just by holding a scope up to the light and looking at the light post. You can see what sort of light you're getting through, can't you?
Yeah, that's a similar brief method we can use when looking to refiber a scope. Obviously, we do many more tests, like with light readings and when we put stuff on the image stack. But yeah, that putting it up to the light and looking at the scope will give you a general idea of how many broken fibers there are in there.
So that's, yeah, again, it's a training thing. I think it's like getting used to. So ask maybe to mention to Julia, just maybe ask the company you're working with on the light leads or the scopes or scope repairers to give you a bit of training, or maybe help write up a training procedure on what to be looking for with that. I've got a question from Neil, who's asked around, which is a bit of an age-old question I've seen around third-party repairs of scopes, invalidating things like CE marks, and that removing OEMs names from the scopes. I mean, personally, that's not something that we would do in terms of removing, generally speaking, as us as a company, removing OEMs names, and the CE marking thing. I think, yeah, my answer to that would be to look up a definition of a CE mark being a product that's safe to go on the market. So assuming that whoever is repairing your scopes can ensure that they're repaired safely into the correct specification, then I think I find it hard to say that a CE mark could be made invalid. But I don't know, Neil, if you got any further thoughts on that and you want to type back, then please do. And Adrian likes your comment around triggers broom, Nick. I think that's quite a good.
I should explain that for the Americans. It's a broom with two pieces, a handle and a head, and he had the same broom for 30 years, and he had 15 heads and 45 handles or whatever.
Yeah.
It was funnier in the actual. It was funnier on the actual comedy show than I've just explained. But there you go.
I can see why you're in scopes and not comedy, Nick. So, interested in Neil's just kindly added. Sometimes the OEM says the name should be removed if the parts are not used from the OEM. Well, I mean, yeah, I mean that's I guess that's again down to OEMs, and it's difficult to make a definitive comment around that. But I would always say, and not just speaking from our business perspective, but to try and retain all the information you can from a traceability perspective. Yeah. So, if any other questions, please feel free to put them forward on the panel. I had one question myself, Nick, which was just around, we see the medical device regulations and are changing. Obviously, that's been delayed now for a year because of COVID. But interestingly, some scopes, some rigid scopes that fall into the lower classes, which I presume would be the diagnostic scopes rather than therapeutic. So they're currently on the lower level CE mark, but there's going to have to be a significant increase in the cost to regulate those when the new guidelines come through and they have to be have a notified body intervention. So is that something where we might see, because it's certainly something that I've been considered on the instrument side of things, maybe companies who are manufacturing the endoscopes decide not to carry on making those scopes because there's obviously, you know, the cost to regulate versus the cost they can get for the scope. What could be the reaction for that?
Yeah, I mean, I won't be too controversial. I try not to be too controversial with this. I'm trying to be as generic as possible. But obviously, as you know, these device regulations have a function in terms of trying to improve quality. But where with sort of any regulation, whether it be compliance or whatever, the cost will go up for manufacturing. And on the simple basis, if they're not making very much on that particular item or in that particular country, you may find that manufacturers will stop making or stop marketing in certain areas of the world. And I think that's already starting to happen. And the downside for the end user is logically then there'll just be fewer people in that marketplace, which will probably increase the price in that place, which is not great for the end user.
No, it's something that we considered with instrumentation, and the MDR implementation date, which was I think originally supposed to be yesterday. Officially now you're not meant to launch any new surgical instruments, so that's the innovation is stifled, and it is a concern that obviously you have to have the right amount of money versus the investment to actually regulate. So yeah, just a final question from me, and then we'll conclude if there's nothing else coming in. Was just around what obviously starting off elective surgeries. I know you mentioned about the power tools and potentially condensation causing issues with rust and stuff like that on power tools that may be sitting around, but is there any one thing that perhaps people could check on their scopes to ensure that that they're fit for purpose, you know, if they've got limited time and resources to have a quick look over them?
I would just, as we've highlighted, just go through the inspection, a very brief inspection that we're talking about. You know, have a look through it, check all the surfaces, check the light, and that's really it. I wouldn't do very much more, but I would do that in everything in the tray. It's not just the endoscopes. It was look at absolutely everything, and
Yeah,
I think anything that's mechanical. You know, mechanical things like being used regularly, and if they've not been used and there is condensation or fluid that's been left in as a result of a cleaning or a disinfection process or sterilization process, definitely check it out that it works, because it's a nightmare for the surgeons if they started and then he or she doing that procedure finds that hardly anything's working.
sure. Okay, thank you. Just had something that that Jack might be able to give us a bit more information on. So another question, just around standards of repairs, and Jack, do you see sometimes in the repair shop scopes that are perhaps being repaired and not followed the correct sort of systems, like tube systems and things like that?
Yeah, unfortunately, we do get a lot of repairs come to us that have been repaired elsewhere, and you know, in some cases they totally go against the rule book really, and you know, use parts that aren't appropriate for the scope. Maybe you know, it could be down to something complicated, such as the rods aren't compatible with the system, even though they're the same dimensions. You could have different spaces, so it's creating minor shadowing on the images. You know, you can find counterfeit parts like in the shaft, pretty much anywhere on the scope really, but unfortunately it is something that we do see quite a lot.
Okay, well, that may be something that sort of links up with what the question from Neil around whether the OEM would want their name on the scope if it was, you know, not following the spec that they'd originally designed, perhaps. So, you know, that sort of helped me to answer that question a bit. And just finally, I was just seeing if I had any other scopes. Right. So, Nick, I won't completely put you on the spot with this, but obviously as a former working for a company that was manufacturing scopes, obviously we mentioned about the baskets and them causing damage for the endoscopes. Why aren't scopes provided with perfectly fitting baskets that are always appropriate for reprocessing? Is that something that is factored in as part of the design of the device, and maybe the new regulations will see necessity for that, perhaps?
I mean, I can't speak for all companies, but certainly my experience was actually they're provided with a basket which is fit for purpose, but it's just for the scope, and obviously people want a tray for the procedure, and that's the problem. And it was certainly from my previous company's perspective, it was a beautiful basket, but most people just opened it and chucked it away.
Yeah.
So that, you know, and if you've anyone on the line have ever looked at sorting out kits, so you actually have a kit for a particular procedure. So many different surgeons want different particular things in that kit, and it then becomes a problem. So you need flexibility. So I think, you know, the endoscope manufacturers to produce, I see no reason why they can't produce a generalized tray that they've approved from a testing perspective, that it's good to keep the endoscopes safe and secure. But in general, that's not the case. They've generally just produced something which is a one instrument basket, a tray for that particular tray.
Yeah. Well, it's as you say, it's a tricky one, because it's not, you can't anticipate every scenario and where those scopes are going to be used, can you? You can't see, you know, necessarily know what the instrument's going to be used with or what instruments they've got. So I can see why that would probably be a challenge. Just have another question here from Michael, who's kindly sent typed up another question for us. So he's saying, have you seen a trend to use single-use rigid scopes? Not something that I've seen in the UK, but you might have some experience with.
I mean, no. I mean, I'll give you a very generic response on that. No, obviously, everything is single patient use, and generally single patient use. There are advantages and disadvantages. The same with scopes as with everything else. So the same issues of cost, performance, etc. Well, from a performance perspective, I mean, if you take a single-use scissor, you could argue that a single-use scissor might be sharper than a scissor that's a multiple-use scissor that's been in a tray for a long time.
Yeah.
There again, you could argue you should have a service contract.
Oh.
Multiple patient use provider and make sure they sharpen it. But from a scope perspective, you'll probably get inferior optics from a single patient use purely from a cost perspective. They'll have to keep it down. Did you hear me? Okay.
Yeah, the audio's dropping in and out a little bit. I mean, so obviously the gist of that for me was that basically, and hopefully will answer Michael, is that okay, no problem. So hopefully to answer Michael, that obviously
just told me to turn my camera off.
Okay. The is the cost factor. So obviously, you know, you're assuming you're going to get better quality lenses for on the reusable scope rather than the single-use scopes, but it may be something that we be interesting to watch this space on from a UK market perspective. I think that's all the questions that we have. Nick, have you got anything else to add?
No, I'm good. It sounds like my technology is better now. So
yeah, I think it's got to put some more cash in the meter. I think something's going on. Thank you everybody for joining us, and really appreciate all the questions we've had. That's made it really, really interesting. Good to get all the different perspectives from around the world. So yeah, we're hopefully going to move forward and do another webinar series at some stage, and we'll keep you all posted on that. So yeah, thanks for listening in and your interest. Thanks to Hank for chipping in with a couple of questions from over in the States. So I would advise, if you don't follow Beyond Clean podcast, to have a listen to it, because certainly it's very, very interesting from a perspective of everything decontamination. So highly recommended. And great, thank you everybody. Stay safe. And if you want to download this to view again or to forward to colleagues, it'll be available in the next day or so. Okay, great. Thank you. Goodbye.
Thanks. Bye.
Thanks, Nick. Thank you very much.
Bye.